We know that as we start to age, decrease mobility, and then most women will have something that happens catastrophically, and then it's almost like then they just fall off a cliff, fracture of their bone because there hasn't been kind of some care towards that. That's where we really start to see significant decline in quality of life after that happens. So it's almost like we're like ramping up to this increase of risk, and we're not stopping it anywhere.
Dr. Jessica Shepard, she's a board-certified OBGYN, menopause expert, and chief medical officer of him and hers. She focuses on evidence-based, accessible care for women across hormones, sexual health, weight management, and longevity. When would you recommend women start or look into HRT?
There's no magic age to start, but what I do know is that women in their 40s do start to feel these shifts due to the estrogen and progesterone ratios, and I feel that's where we have to do a better job at teaching women body awareness and what's really going on. Within the first 5 years, you're going to get the best benefit, but also timing before menopause is also beneficial. Inflammation is the key to everything. Sugar is probably the number one cause of inflammation. Estrogen itself is an anti-inflammatory, which is why we see after menopause, we start to have an increase in cardiovascular risk because we're increasing inflammation. Once people really understand the internal inflammation that occurs on a cellular level, I think that's really where we're going to help everyone understand the small things that they can do.
Well, I'm so excited today to have an incredible guest on the podcast, Dr. Jessica Shepard. She's a board-certified OBGYN, menopause expert, and chief medical officer of him and hers. She's the founder of Sanctum Med and Wellness in Dallas and a former chief medical officer for Very Well Health. She's the author of Generation M, Living Well in Perimenopause and Menopause, and a frequent medical voice in national media. She focuses on evidence-based, accessible care for women across hormones, sexual health, weight management, and longevity. Well,
Yeah.
welcome to the podcast.
Thank you for having me. I'm so excited to be here. I followed your work for years, and it's just fascinating to see one in the longevity kind of ecosystem of where we've gotten, but specifically for women, right?
Yeah.
Yeah.
Well, thank you. I appreciate that. I mean, we've chatted about this a lot, but
Mhm.
women have just been so left out.
Yeah.
And when I decided, so I started, and then we'll jump into the podcast, but when I started to do a really strict longevity protocol, we incorporated a lot of this like extra fasting and caloric
Mhm.
restriction. And I watched my thyroid, decline and my hormones become dysregulated. And so I hired a small team of female PhD researchers and candidates, and we did not find much in the literature to even
Mhm.
apply to a longevity protocol. So
Right.
that's why it's important to have conversations with, experts like yourself and just explore on our own. Because
Yeah.
if we wait until there's 100 randomized control trials on what we do for
We'll be waiting
longevity,
for a long time.
yeah, we're going to be waiting for a long time. So super excited to get into all things, female health, menopause, longevity with you today. I think we would be remiss if we didn't start with what's recently happened with the removal of the black box warning. If you could just give anyone that's not familiar with how
Mhm.
that happened and now what we have to celebrate, I would love that.
Right. Let's start with the celebration first. Was this week was this hallmark of removing the black box warning from all hormone therapy. So this was done by the FDA. The black box warning, just to give it context, is one of the strictest or most severe categorization of
Mm.
how the FDA can give you recommendations to either have caution about something or not take something. And so the black box warning was put on hormone therapy as a result of the WHI, which was done in the late 90s, early 2000s. And the reason it was put there was, again, if you look at kind of the domino effect of what happened was the WHI was set out to look at hormone therapy
Mhm.
in cardiovascular risk. So it had
Mhm.
nothing to do with menopause, quite frankly. And so from that, there was an arm of the study, and that's why studies, and you would appreciate this from research, is that we're looking for things that can help us improve or things that we should be cautious about and, kind of take maybe, a halt or a pause. Now, in the study, in the arm that had estrogen and progesterone, namely a synthetic progestin,
Mhm.
did show increase in breast cancer. But from a study perspective, you're really looking for significance in, is this something that is extremely different to if you did not have that or that exposure? And it was not significant, but it was the synthetic progestin that actually increased breast cancer. So from that, the media took that as a soundbite and basically came up with estrogen causes breast cancer was pretty much what we heard. And so for 23 years, that black box warning was put on shortly after. And rightly so, for someone who doesn't understand hormones to see a warning like that would say, I'm not going to take hormones because I'm going to get breast cancer. And that was what was filtering through the air. And so now 23 years later to see that, one, the research was always there that proved that that wasn't true. And for women, standing up and saying and advocating that this is enough. I want to be able to, have control on what I want to take for myself and, for my health. And then for providers, having the ease, at least have a better conversation because that black box warning is removed,
Mm.
to giving women the option of understanding hormones and then saying yes or no. It really, at the end of the day, should be an option for women to take. But with that black box warning that was there, it really did kind of put a really deep shadow over the conversation itself of estrogen and then saying that it causes breast cancer. So that's removed, and we're really celebrating. But a lot of work still needs to go into that because you still have to dispel the myth and help women understand the importance of estrogen and progesterone therapy.
Yeah. Do we think that because that's removed now, that the education will go into medical schools? Because that was a huge problem, right? I mean, my mom is 53 and she, went into menopause about 47. I'm, telling her you got to get on bioidentical HRT. She goes to her standard doctor and immediately she's told that, it will give her cancer, right? So ideally, I think, and you might agree or disagree, but one of the big things that we have to remedy is like the training for
Oh,
doctors,
yeah.
right?
That's where we're fundamentally going to have to start this change in the culture of what it means, because ultimately it is the prescriber
Mm.
who is going to be able to get patients what they need. So there fundamentally needs to be a change in the education of this so that then when providers are trained and come out and are able to speak to hormones in a positive way, but more so obviously in a way that they can um, inspire or encourage women to think about it differently is another caveat. But I do think that there's going to be a lot of work that's going to have to undo what was done,
Yeah.
the education perspective of that, and then allowing really science to prevail and show the benefits of hormone therapy and allowing women to really make that choice for their lives.
Yeah. That's actually my next question. So the internet is a little bit confusing. You
Is
know,
it?
it is, yeah. It's actually very divisive in terms of menopause. I thought we were making a lot of progress. I was seeing great, comments and great videos. But then recently I've seen some more, I guess, negative commentary about maybe our claims are too strong about
Mhm.
what HRT can do.
Yeah.
Not, you've probably seen some of the same. So, can you tell us what does the research really say and what doesn't it say? Like, what can women expect?
Yeah, this is again why research is so important. Another part of that conversation I really do believe is yes, research is very important, but individually for every person who walks in that room, research provides evidence-based metrics, a study, what were the numbers, what was the population, what was the outcome.
Mhm.
But now, when we bring that down to an N of one, for every person who's walking into a room, they still have to weigh risk versus benefit.
Yeah.
And so that's what the study can provide is here are the risks, here are the benefits. But someone could still say, even with those risks that was presented in that specific research study, I'm willing to take that risk in order to reach the benefit. But that's an individual choice. So I obviously have seen a lot of that discourse that is happening when we look at the actual data and what's been coming out. What I do find is you'll see this anytime you have multiple studies, looking at the type of study it is it prospective, is it randomized, double blinded? You are going to have different outcomes.
Mm.
So I think because of the conversation in hormone therapy alone, just because there have been multiple studies done and some of them have different outcomes, now that we've come to a point in, I guess you can say, the translation of hormones, there needs to be now a coming back together to solidify and say this is what we are going to say as far as the risk and benefit when it talks about cardiovascular disease, when we talk about cognitive decline. That's probably the one I've heard in the last few months that has been the most controversial of that. Does it Does it create? Does it take away from cognitive decline? And there was one post, which is why I'm glad, one, there's research and social media, is that there was a researcher who came on. Her name is Dr. Pauline Mackey out of Chicago. And she had done the research at looking at cognitive decline and does it help prevent? And from her research, she was showing that it does not.
Hmm.
Now, does that mean that we stay there and we're just like, we're not going to give anyone exposure to estrogen just because it doesn't?
Yeah.
That's where the conversation becomes, but there are a lot of other benefits as well. This is what we also can extract from taking hormone therapy as well. And I love the fact that she was able to break down her study and look at it and explain what her actual research was and what her proposed hypothesis was, and what she even said herself. She was able to prove that it didn't, even though she thought it would.
Hmm.
So, where do we go from that? That is, again, the beauty of research is to now take that and move forward, because we do have other data and other research that has shown that they did see an improvement in cognitive decline. That is what science is being able to take a study, and even if there are differences in the outcomes, is still furthering the research
Mhm.
and then coming back to what was done and seeing where we make that shift and then implementing it into clinical medicine. So this is where the time and, effort goes behind, healthcare providers prescribing, PhDs doing that bench research. And I think we are in a society where we kind of want it to change overnight.
Mhm.
And that's not how science works. But are we so far ahead than we were 50 years ago? Absolutely. And so, I am pretty much one of optimism, where we take the wins. We're going to take the wins and we're actually going to utilize those wins and put that into clinical practice.
Yeah.
And all in the background, we still do that hard research that's required and warranted.
Yeah. I love that answer. And I think it also, I also had a medical clinic for years and I got to see the patients and their stories, right? So there's such a stark difference between, sometimes I do things like an ozone sonde, mold, on mold protocol. And then some of my researcher friends are like, oh, I haven't seen any research on that. I'm like, yeah, but I've seen, 300 people have mold labs, then do the intervention and then not have it, and it's made an improvement. So there's just such a difference
There's
between
such a
what is
difference.
proven in the clinical research and what you see on an N of one basis with a patient,
And
right?
that's why I love discussing that with you, because even in just the word longevity itself and where we've come, I know even if you were to look at longevity and the protocols that you've made and where this whole kind of world of longevity was 5 years ago, you can even see the changes and the differences and what's been brought out in an innovative way or technology way, but also just what people feel better from that may not have the best double blinded, randomized, control study, but you're like, "But there is something that's working."
Yeah. Dr. Sarah Gottfried, well,
Yeah,
Zoll now, is
yeah.
actually my consulting longevity physician.
You're amazing friends, I love her.
She's amazing.
Yeah,
Harvard trained
yeah.
OBGYN. She's great. And, she had told me, now on a few occasions, but she actually feels that N of one, which of course is not possible for
Mhm.
everyone, but if you can do it in the right way, is one of the highest forms, right?
Right.
Because you're taking your own data, your own genetics, your own biology, and then you're testing against that.
Yeah.
And even if you have a test of a different cohort, they're not you.
Mhm.
So I think that will obviously be the future, for
And
any.
that is the future, I think, of using still that data. I think that's still really important to have, studies that have a large power and showing what can happen in the majority of people.
Mhm.
But even using that data and then saying, okay, now I have a wearable, or now I know some of the data that's been proven or shown in longevity and I've tried it and it works. That's the N of one. That's the power of the N of one, is utilizing both. And I feel that in my practice, that's how I want to convey myself and how I, practice, is this evidence base is very important. But everyone who walks through that door has a different story. And I'm willing to kind of shape shift the puzzle pieces together until we can figure out what that person needs.
Yeah, I love that. Well, last question on HRT before we move into other
Yeah.
longevity topics. What age? I think that's been moved a bit. So when would you recommend women start or look into HRT?
There's no magic age to start, but what I do know is that women in their 40s do start to feel these shifts due to the estrogen and progesterone ratios. And I feel that's where we have to do a better job at teaching women body awareness and what's really going on. Is that something that is impacting my quality of life? Have I been trying to, grin and bear it for 5 years versus maybe 2 months?
Mhm.
And that's where the conversation now comes in with an expert who's able to say, huh, well, yeah, you've maybe had it a few times. Let's maybe see how you can go on a few months without it. But if it's severe or even moderate, or you feel that even at the low level it is, you want to start it, absolutely. Timing is everything. Again, going back to evidence-based research. Now we do know waiting till menopause, which is the average age of 52, to start hormone therapy. Within the first 5 years, you're going to get the best benefit, but also timing before menopause is also beneficial because we're actually helping the functionality of the organs in which the hormones respond to and communicate with by giving hormone therapy. So I always advocate for women in the perimenopausal phase to start the conversation. And if they get to a point where they need to start, absolutely. When I was trained, we would really wait till someone was like menopausal. We would like over and over, "Are you sure you haven't had a period? Are you sure there was no spotting?" And these men were suffering.
Yeah.
But it's like we were so fixated on making sure they were menopausal before we could start,
Mm.
where now I'm just like, "What are your symptoms?" Endpoint. What are your symptoms? And what
Yeah.
can we do to abate those?
Yeah. Do you start with any particular, or so do you start ever with progesterone and then add an estrogen later, maybe testosterone even after that?
I love the way you position that because I say this, which I would not advocate, especially on your podcast, but a Cheesecake Factory menu, you know how
Yes.
there's like 86 pages? You're like, we're at one restaurant. How is this possible? That's how I approach hormone therapy is
Okay.
someone might need a patch, a pill, a cream of estrogen. Someone might need no progesterone. Someone might need just testosterone or TNP. I always say it's like the PET approach. Let's see what your kind of algorithm is and we'll figure it out over time. That's the other thing is having patience with it
Yeah.
is we are really adjusting to your epigenetics and your kind of result in what's going on. This will take time, but I'm prepping you for the next 40 years of your life.
I love that. I have a question. So, is it if you let's say you enter menopause and then you wait 5 or 10 years, is potentially one of the mechanisms as to why it's not as effective? Do you lose any of those receptors? Like, for example, in the brain, if you
Mhm.
have nicotine, right, you get more nicotine receptors. If you
Right.
don't have it, you lose those. Do we lose some of those receptors?
It's more the sensitivity of the receptor.
Okay.
And in addition to that is the organ that was responding to that hormone.
Okay.
So now you have with aging, right? So superimpose aging on top of that, you have receptor desensitivity or a decreased sensitivity, but also you have the organ that was relying on that hormone to
Mm,
function has not been there for now 5, 10 years even.
yeah.
So the ability for it to be to the capacity of what it was when it was with hormones,
Mhm.
that's what we're looking at is that outcome and also the hormone sensitivity of the receptor. And so I'll give you an example of if someone comes in at 60 and they're like, I want to start hormones.
Mhm.
That woman really does have the ability to start, but now the conversation changes and saying, let's look at your heart and what maybe plaque has formed in your
Yeah.
vessels, what the output is of your actual heart, looking at things like VO2 max, because that conversation is not going to be different than if I had started you within those first 5 years of menopause or in the perimenopausal transition.
Yeah. Well, thank you. That is so helpful. All right, let's get into longevity. I want to first start. The way that I think about my longevity protocol, it is what are the top risks for women, right? So, would love to hear, what you think of as the risk. We all know the standard risks, right?
Mhm.
Cardiovascular disease, Alzheimer's, but is there anything else that you're adding into that bucket for women?
Yeah, I think maybe my top one, because cardiovascular disease has a lot of different things that can create that kind of conundrum, is frailty.
Mm,
And frailty really goes down to like the complex of your muscle and your bone. I always look at it kind of like one nice little unit that they play well together in the sandbox and they need each other.
mhm.
And then the other thing that I would actually look at is cognition.
Okay.
Cognition is one of the biggest things that we see. And I know that you talk about this often is actual cognitive decline, Alzheimer's, and even though men have more cognitive decline than women, Alzheimer's, two-thirds are women. So there's
Mhm.
something there that accounts for that specific process that occurs in the brain, the inflammation, the plaques that build. But frailty is another one. I would say that probably is my top one because we know that as we start to age, decrease mobility.
Mhm.
If we don't have the wherewithal to know that strength training is going to improve our bone and our muscle,
Mhm.
is that we start to see a significant decline, especially with women not having the flexibility or the balance. And then also now, if they do take a fall, right, because they
Mhm.
don't have those mechanisms to, withhold themselves up, is then we have fracture of their bone because there hasn't been kind of some care towards that. And then that's where we really start to see a significant decline in quality of life after that happens. So it's almost like we're like ramping up to this increase of risk
Mhm.
and we're not stopping it anywhere. And then most women will have something that happens catastrophically. And then it's almost like then they just fall off a cliff when we
Yeah.
think of quality of life, specifically to longevity.
Yeah. What are the stats? I used to know them, but if you have a broken hip as a woman,
Yeah, it's in the 70th percentile as far as like morbidity and
yeah.
decreased quality of life. That is like huge as far as what you can look for later on in life. If 40% of a woman's life is spent in the postmenopausal phase, right?
Mhm.
So from the time you hit menopause, whether that's 52 or 54, 40% of your life is spent in that phase. Why are we looking, when we look at lifespan and health span, such a big gap for that last 10 to 12 years of a woman's life that's spent really in a lot of poorer health?
Mhm.
Where I use a slide when I'm speaking, and that gap in between those two,
Yeah.
the goal is to try to narrow that gap.
Yeah.
And that's one of the things that I think contributes significantly to decreasing that gap.
Yeah. Yeah, I mean, it's wild to me that, bone density peaks at 30 and most women are not getting a bone density scan until about
When you s
65.
when you said that earlier, I have been saying I was just like, "Why would that be the recommendation to look at bone when pretty much it's like powdered bone
Yeah.
by then?"
I
Like,
mean,
why are we not looking at it when it's strong and the trabecular network of bone can actually be improved
mm,
as it's declining?
yeah.
So, when I look at, we could have a whole nother podcast on just health outcomes and then our health care in America and how broken it is, that we would think that that was a good idea to screen women for bone when they've been probably 10 to 15 years without estrogen and their bones probably have taken a hit since in their mid 30s.
It's, like, unbelievable, to
Yeah.
be honest. So,
Yeah.
if you're listening to this podcast or you're here, I mean, a DEXA scan, I think, can be, like, a couple $100. I
Yeah.
mean, get one as soon as you can so you have a baseline, and then it's going to be so much easier for you to improve that now.
Right. Like, what if I were able to give you the tools and I'm like, hey, you're in your 40s and I'm seeing some shifts happen in your bone. Do these things on a daily basis
Mhm.
that are just incorporated into your lifestyle, whether it's with resistance training, weight training, jumping,
Yeah.
increasing protein in your diet to help you when you're 65. Like, I don't know. It's yeah. We're gonna change that. You and
Yeah.
me together.
I
We're
love
gonna
that.
change the DEXA scan age.
Yeah, I mean, I agree. Yeah, I mean, for me, jumping, I do a lot of
Yeah.
like jump roping, box jumps, loading the bones, compound lifts. Of course, if you haven't done them, get some training on that. But I mean, and I measure my bone density, and my bones are like, doing great,
Yeah.
and they're gonna keep me doing great because I'm committed to
Right.
maintaining that. So I really hope we're in a place that we can all change our mindsets because we
Mhm.
do have so much power over our eventual outcomes.
I think that's probably like should be the hallmark of the entire podcast is what you just said. We really do have the power to change our outcomes. And they don't have to be huge strides that like, you have to like reconstruct your entire life. It's small interjections
Hmm.
every day with consistency that will reap you this huge benefit in the future.
Yeah, I mean, I couldn't agree more, and I love that. Well, on the topic of testing, what are some other tests that you like to do with your patients for longevity?
I look at longevity and, because you and I like speak about this all the time, there are people who are just like even hearing the word or trying to understand what it means. So I always start at a very basic level of what longevity is and what are some of the testing that they can get. For women who come into my office, I obviously, speaking of perimenopause and menopause, I always do a hormone
Mhm.
kind of panel to see where they are. It doesn't necessarily mean it's going to be diagnostic or tell me what I should do with their hormone therapy,
Mm,
but it's good to get a baseline. The other things that I look at are your ApoB, your lipid panel.
mhm.
Hemoglobin A1C, that's one of the ones that probably I focus on often
Yeah.
because people don't understand the glucose and insulin shift that occurs in midlife.
Mhm.
Um,
May I ask,
yeah.
what do you want, those numbers to be? So ApoB less than and HbA1c.
Yes, hemoglobin A1C. Well, when we look at the reference range, right, 5.6 is where we start to get into that pre diabetic phase.
Mhm.
It's different on age and based on where their life is at that moment, right? Because the one thing too that testing can be is very dreadful,
Mm.
right? And so if you present it in a way where someone is like, "Oh my god," and that's usually what comes back if they're close to that number, people it almost like incites more stress. And so how do you decrease the stress with the result is then the other part of the lifestyle is we're not going to fix this by tomorrow,
Mhm.
but what I want to encourage you with is a lifestyle change and shift that if we start to work on it, it may be a year before we get to that optimal number. Obviously, if I were to say optimal, I would want you in maybe like the 4.5 to 4.8, but that's not
Mm.
easy to attain.
Yeah.
But taking the fear factor out of everything is probably where I spend most of my time because we have conditioned with labs
Mm.
people to be fearful of a bad lab, which is why a lot of people don't even go to the doctor because they're fearful of the potential outcome or diagnosis. It is,
But that's
I know,
but that is not solving the problem,
it is not. And I think that, I can even say, being part of that responsible part of the system where that's what we do as doctors. We are very good at making people feel very afraid.
Mm. Yeah.
And so even we need to change how we message, how we respond and talk to patients when they come in order to create more encouragement,
Yeah.
motivation, because the lifestyle change for all of my patients is the hardest thing to instill rather than me giving a medication,
Mm. Yeah.
right? How do you shift that? That's a very big shift,
Yeah, yeah, that is, and I think it's so hard for me to speak on because it's so natural to me, like, I'm obsessed with this. I
right?
can't wait to do my labs because 'cause I'm like, "Did we get better?" Or, like, "Is there something I can improve?" I'm, like, so excited, you know? So
When I want to ask you a question because you live in that space, in that world. When you do talk to people who have maybe not navigated,
Mhm.
what do you use as questioning or techniques to get them to come over to the side of longevity?
Yeah, I think it's building excitement around the fact that no matter what the result is, you can make substantial progress, right?
Mhm.
Like you can actually fix most things. Of course, some things are outliers,
Right.
but everyone that's listening, HbA1c is a 3-month measurement of your glucose. So it's like you can just change your diet and a little bit of exercise, and then you can get that number to where you want it to be. So I agree, like you want to wade in easily and maybe just start with
Mhm.
a small panel, because if you do a really deep dive, you're always gonna be finding something,
Oh,
to
right.
work on. Like, I'm always working on something. But yeah, just building that excitement around, hey, even if the number's not perfect, we can get it perfect, and how exciting is that?
And I think the exciting part is I'm excited about it too. And then I do like to ask everyone who walks in my office, like, what do you identify as your struggles in your individual life that may be hindering you?
Yeah.
Because I can't make assumptions. And I think that when everyone walks out of my office, as excited as you and I are, they walk back into an atmosphere that has created the hindrance itself, like
Yeah.
whether it's family, atmosphere, environment, even like negative thoughts or negative speaking to yourself. Like those are all things that play a factor into it. And I think that's where, even I struggle, and just like everyone else, of what is that thing that you're trying to ultimately change, but something is hindering it can be sometimes the hardest thing to kind of change in
Yeah.
your life.
Yeah, I mean, I always and I had to do a lot of deep dives on this myself. You have to believe that you're worth it, right? Like
Mhm.
you have to have confidence that you're worth good health because you're never going to put the discipline in that it's going to take to get there
Yeah.
if you have those thought patterns. So I think, before you even get into the lifestyle habits, you really have to, you mentioned going to therapy. I've done
Yeah.
therapy in my life. I've done a lot of different, kind of techniques to work on that part of it because you are worth it. And once you realize that, then you're going to be more excited to put in the work that is required. But I also think our society has created this culture that we, for some reason, like if we actually take a step back and think about it, so something good happens and you want to celebrate. How do we celebrate? We celebrate with alcohol, which is a neurotoxin and increases your risk of cancer, and in particularly breast cancer for women. And then, or we go out for a huge meal that is going to make us feel horrible, or we stay up super late. I mean, who decided this? This is like my antithesis. People
Yeah.
are like, oh my gosh, do you enjoy life at all? And I'm like, enjoy life so much because I wake up with great energy. I feel good all the time. Like, I mean, way back in the day when hangover is horrible, that doesn't feel like a celebration. So I think we do need to just change the culture around how we celebrate.
I think society has created something that, and again, it's like one of those conspiracy theories, but it actually does make sense of what you just said of like what we truly celebrate, which is sugar and alcohol, which internally our bodies are, don't necessarily need that nor require it or want it in order to have optimal health. So there has to be a lot of shifts in society. I think particularly for women, I think society has not given us the luxury to be seen and heard when
Mhm.
it comes to a complaint
Yeah.
and leaning into that. So sometimes we shift away from that. So we've all done it, right?
Yeah.
Every woman has gone through menopause, so you'll be okay. But now I think what I've put overlaid onto that, because there are some patients who are like, you know what, I'm going to try and get through this alone or not having to talk about it, is bringing in those health implications, which longevity speaks to
Mm.
is, yeah, we can talk about right now and what you may want to do right now for your symptoms and maybe, just kind of grinning and bearing it. But I want to talk about how you want to show up in your 70s, 80s, and 90s.
Yeah.
That usually is the best way I can kind of create oh, I do need to plan for that. It's the same thing of, as a health is your investment. I would never tell anyone, okay, when you actually retire, then you should start saving money.
Yeah.
It
Okay.
that is not gonna yield anyone any good return on investment, so the same thing applies for our health. And midlife, the more that I study midlife and perimenopause and menopause, from a metabolic perspective, from a mitochondrial health perspective, that really is the categorical time in which someone should say, I have an opportunity right now to predict what my 70s, 80s, and 90s is gonna look like if I can make some small tweaks right now, which you just said, whether it's like doing jumping rope or jump boxing, or I'm gonna add more protein over time over the next 5 years into my diet, or I'm gonna make sure that I wear a wearable so I can see what my sleep habits are like.
Yeah.
Those are, I always say, this 15-year time frame that we have for women.
Mhm.
You can see that if women do make those small changes over time, that we know the data shows that
Mhm.
they're gonna decrease those risks of cardiovascular disease and, cognitive decline in their 70s, 80s, and 90s. So I'm like, let's prime you now for then. That sometimes seems to shift the ability to say, "I'm worth it then, and I need to do that change now and that shift." But I think we've come to a beautiful place in longevity for women over the last 5 years of focusing on them specifically, but now it's like the timing. The timing is key, and I
Yeah.
think that's where we're moving into this next kind of, layer of longevity for women is timing.
Yeah. I saw an interesting post and I just saw it today. So apparently there's a new study out. So if you haven't seen it yet, because
Mhm.
obviously you've been very busy, but it was looking at ovarian aging. Obviously, I'm obsessed with this. And that apparently there's a lot of a deep relationship between stress and the ovarian aging, not just the, loss of the eggs. Have you seen this yet?
Yeah, a few of my PhD friends who really focus on ovarian aging, Dr. Pariah Bayam out of New York and Dr. Jennifer, she's at UCLA for what's her last name? I'm
Garrison?
forgetting.
Yeah.
Garrison, yes,
Yes.
what Dr. Jennifer Garrison. And what they look at is fascinating in exactly what you said is we have this organ that for centuries has had a time clock on it,
Mhm.
which was menopause, which explained why life expectancy was around 59 back in the early 1900s for women. But now that we have expanded life expectancy for women, we have not accommodated for that gap without estrogen.
Mm.
And so the goal is to expand ovarian function or age and the ability that it has to give the hormones of estrogen and testosterone as well for a longevity standpoint, not necessarily for fertility. Now, I know that there's some offshoots of, kind of delaying menopause from a fertility standpoint, but most of the time I've seen studies has been to improve longevity. I think that's where we are going to see the next wave of science, because it truly is the only organ that kind of, I don't want to say the word dies, but pretty what goes into oblivion, and we have serious repercussions of our health that occur because of that. So why not find out a way to expand the lifespan of the actual ovary to improve longevity?
Yeah, yeah, I agree. I mean, a few things that I'm, kind of trialing is the rapamycin. Have
Yes.
you seen the Vibrant study?
Yeah, I have
And
seen that.
obviously, it's not fully done, but I mean, super exciting.
Hmm.
And then just like first principles thinking, like this entire inflammatory cascade that goes on each month. So I'm trying to offset that a little bit with like some red light therapy, some strategic HBOT. I don't have any conclusions yet, but I'm excited to share them when I do. But
Inflammation is like it's the key to everything. The more that we can decrease inflammation, we had even mentioned it on our talk before of, yeah, sugar is probably the number one cause of inflammation, but chronic stress over a long time. So duration of stress, and looking at that, but also estrogen itself is an anti-inflammatory, which is why we see after menopause, we start to have an increase in cardiovascular risk because we're increasing inflammation. We see that the glucose insulin ratio is not adjusted as well. So we start to see our visceral fat increase. And what does fat do? Increase inflammation. So it's this whole cascade of inflammation, which I'm fascinated to see what your outcome is with those modalities that you're using to decrease inflammation. Because once people really understand the internal inflammation that occurs on a cellular level, I think that's really where we're going to help everyone understand the small things that they can do. Inflammation is, yeah, that's really like the daily fight is how do we decrease inflammation?
yeah. Yeah, well, going back to labs, because we actually didn't quite
Oh
wrap
yeah,
up on
we
so
got
we gotta
really far off of lab.
okay, so you talked about doing the ApoB, you talked about, the HbA1c,
And then
what other
thyroid.
thyroid, okay.
Thyroid is one that I run, and here I wanna give a good depiction of thyroid, is typically we have focused on the disease
Mhm,
of thyroid, whether it's hypo or hyper,
mhm,
but when we look at the normal range or the reference range of thyroid, it's almost like you're within normal range, but you can still be low normal,
mhm,
mid normal, high normal. And so there's ways to optimize thyroid as well. And I think that's what we have missed in traditional medicine a lot, is looking at just a lab, either you're in or out,
yeah,
and not looking within the gray of what are you within normal as well. And then helping, I think lipid, obviously with statins, that's another controversial kind of topic of, do statins help? Do they not? And looking at long-term outcomes with statins is helping people understand their lipid profile before. So it's a lot of it is like prevention
mhm,
and understanding what it is before you actually get to the disease state.
mhm,
And the way we are trained in traditional medicine is to wait until there's a symptom that occurs and then finding the disease because the symptom occurred. So the goal really is, how do I keep someone in their well span for as long as possible?
mhm,
And that's what prevention is. Prevention is key, but also being preventative with labs. That's why it may not answer all the questions, but it can provide a good framework of where we want to stay if someone is still not, abnormally
mhm,
or abnormal in their labs, and how do we get you to stay there?
yeah. Where do you fall on statins?
I think so. I will bring it down to also ethnicity too. So, if you were to have a cohort of Black women, typically when we look at heart disease, it impacts them differently. And so, statins, especially when if you have comorbidity of hypertension as well,
Mhm,
that can definitely increase your risk of having cardiovascular disease
mhm,
that's more detrimental. So statins to me is still an individual kind of conversation, because one of ethnicity, do you have hypertension on top of that? And then the other part of that is lifestyle factors, right?
mhm,
So where can we find this interplay between, yes, I don't mind you being on a statin because maybe it's very high as far as what your lipid panel is showing, and your LDL and your total cholesterol, but are you also going to do your side of the relationship in helping shape your lifestyle where we possibly could get you off a statin? There are some, people who will just have to be on a statin for life, and that's okay too.
Mhm.
But it's so hard to make just a broad, generalized statement on anything, like whether it's a GLP-1, a statin, even hormones, like what does it really mean for that individual? What is their true understanding of their health? Where did they start?
Mhm.
What is their starting point is going to be different as well. And what are they looking for expected outcomes, and what are they willing to contribute to that outcome?
Yeah. Do you use any PSK9 inhibitors?
I don't.
Okay. Yeah, that's kind of an interesting conversation around
Mhm.
what's better, and I don't know. So,
Yeah.
gonna dive into it at some point. Okay, great. Anything else? Do you do any like grip strength testing at your office or any VO2 or encourage
We
them?
we do CGM.
Uh-huh.
I think CGMs are a great way for someone to visualize
Mhm.
what's going on, and also we have that data to also show them in the course of a day, where are your spikes? How do we decrease those spikes? How do we do that through lifestyle?
Mhm.
How do we maybe implement a GLP for that as well?
Mhm.
The other thing is that with management for hormones, specifically for women in midlife, because there's such a metabolic shift as well, is I was so glad this study came out. This was last year. Is women who are on a GLP will
Mhm.
have better outcomes if they're also on HT,
Mm.
which makes complete sense
Yeah.
because they're all interplaying between each other. So having the data behind that was really helpful to explain to patients. Yeah, GLP is good for multiple things, whether we're treating you for overt diabetes,
Mhm.
whether we're looking at a weight loss, or whether we're doing maybe small doses and microdosing for inflammation. They all have different uses, but on hormone therapy, we can expand that outcome of what we're
Mhm.
looking for in both.
Yeah. Is there anything specific that you're looking at for optimal CGM data, like amount between spikes, duration?
Well, when we look at obviously when we look at the cortisol spikes and when we look at the rhythm of what they're doing with their circadian
Mhm.
rhythm is one is everyone's going to be different, right?
Yeah.
And so we're able to adjust. Are they intermittent fasting? Are they not? What is
Mhm.
their protein versus their macro
Mhm.
intake?
Yeah.
And how can we adjust those? Again, it's very individualized because people come in with different starting points. And so to have an outcome of, I would prefer you to be the most optimized is very overwhelming for patients. And so
Yeah.
I always have to dial it back
Yeah.
to where are you right now and where do we want to be in a month from now, 3 months from now? And I've found that having short term goals
Mhm.
is easier for people to adjust to and take a breath and saying, I can do this versus this is the number you should be at. And they're like, oh my God, I'm nowhere close to that. And then a lot of people will actually deter and they'll just be like, I'm just not going to address it because I'm too far from that goal.
Yeah, yeah, that makes sense. Definitely having a stepping stone.
Mhm.
With my CGM data, I like to see less than 30-point spike.
Mhm.
So, and I'm very much on the extreme end. I think
From
everyone
your
knows that
baseline.
from baseline. Yeah,
Mhm.
obviously, I'm usually around 70 or 75 waking glucose. Like this is some of the data I like to
I
extract from
love
these
that you
things.
were able to say that because, again, we're dealing with people who their like baseline is like, in the hundred, like low hundreds
Yeah,
for their baseline. So
we got to
even
improve that
I
baseline.
know even trying to improve them from baseline, and a lot of it comes from food choices, bad sleeping habits.
Yeah.
A lot of them are far into their menopause journey, so they may have already increased peripheral and visceral fat. So then we're dealing with that as well. So there's a lot of interplay between what we want for them and what they're willing to do on their end as well.
Yeah. Well, we'll just keep encouraging everybody.
Oh, I think that the
You
more
know.
that we have these discussions and we can see the best of optimization, and that's why I love what you do. So people can always have this is what could happen. Like it is not impossible for people to attain it. But if we don't have a goalpost of
Yeah.
what is the most optimized,
Yeah.
then I also think that is not beneficial for people who are looking to aspire to something because it will come in, I guess you can say maybe tiers of
Hmm.
how people work. But
Yeah.
even when you post your things, I run back and look at my data and I'm like, God dang it, she's doing so well. But for me, because I love this, I still aspire to it. I'm like, okay, what do I need to do and
Yeah.
adjust in
Mhm.
order to fix those numbers or
Yeah.
to get that outcome? So I do believe that what you're doing, especially for women, because what we do see in the longevity world, like anything, it started more with males, right?
Yeah.
And them doing things. And a lot of women, I've heard this very often, both on social media and through my patients, is and it's no shame to men, it's that they have the ability to do it, is that what their protocols are, women are like, "How am I going to do that before I feed all the kids, take them to school, pick them up, go to work in between, maybe have, like, a good lunch that I was able to pre-plan and do all those things in it?" And so I think that the luxury of just by nature, by roles, what women might have to do in a day is different,
Yeah.
and so we have to be able to meet them where they are. If we can't
Yeah.
meet women where they are, then we're not doing anything for them.
Yeah. Yeah, I agree. But also love having the goal because
Mm,
if we don't know where we're going, we're never
right,
going to get there.
right.
So, I mean, like grip strength, I think, for a longevity range for a woman, you want to be somewhere around 80 pounds.
I am for my grip strengths, I did test that recently, and I think I was like 82.
Yay. Okay, great. Love that.
That's one metric
Does
that I
anyone in
did.
the audience know their grip strength? Couple people? Okay. So you guys feel pretty good about it? We won't ask the actual number, but hey, you want to, I mean, aim for 80. And everyone's like, "Well, how do you improve grip strength?" Please don't get this grip strength like this little hand grip trainer. It's
Which one
not
do you use?
well, you're not getting any benefit if you're doing the trainer.
Mhm.
So we've got to actually put in the work because what is
Oh, I see what you're
yeah,
saying.
what is grip strength even measuring? It's a measurement of strength, upper
Mhm.
body strength. So, push-ups, dead hangs, pull-ups,
Do you
all
do
sorts of
farmer's carry?
farmer's carry. Yes, I love that. Actually, I'm aiming to I can do about my almost my weight in farmer's carries.
Wow, that's
So,
impressive. Because for
yeah,
males, it's
their weight,
their
right?
weight,
And
and
it's
then
like 70%.
females, it's
Yeah.
70%, and then the hang test is 90 seconds for men,
Yeah.
60 seconds for women.
Yeah. I think it might be 2 minutes for
It's
men.
2 minutes for men,
Yeah,
you're right.
and about 60 seconds. So 90 seconds puts you, like, in the elite level for dead
Mhm.
hang. Maybe we'll just go through some metrics real quick
I'm gonna try right after this.
that I look at. So dead hang, because this is, like, my new obsession is just, like and, I'm not gonna say I have a million pieces of science to say that this is the exact amount of time you should be able to do a dead hang, but yeah. So dead hangs, aiming for at least 60 seconds. I am at about 90 seconds, if you can get at 90 seconds. Honestly, I'm higher than 90, I could keep going, I've stopped at 90, but that puts you in this, like, elite range, and we just should all be elite because we can.
Yeah.
We just gotta work on it. So dead hang, grip strength, aiming for at least 80 pounds of grip strength, let's do that. Go higher if you can, and you certainly can. And I'm not, like, in the gym all day, every day or anything. I just have maintained it over a period of time, and I commit to it. So that's another marker. For VO2 max, I think women should be somewhere around 40 is good. I'm at about
Mhm.
46 right now, so the higher the better.
I
Um,
haven't tested mine in years, so I
yeah.
do need to test that,
Yeah,
yeah.
and I just try to make it well, for me, I mean, I test all the time. I test, like, once a week for most metrics, and I
Mhm.
just keep a linear Excel sheet of tracking to know if I'm getting better or worse. I look at, obviously, body composition,
Yes.
lean mass, muscle mass, and I look at lung health, so that's like a little spirometer if you wanna
Mhm.
do that, but I do my grip strength every week, and also, blood pressure, I think, is an important metric. I actually got this cool new blood pressure cuff, it's called Connect, and it measures arterial flexibility, or at least a proxy to it. None of this stuff is perfect. You should still calibrate it against an in-clinic, like DEXA, obviously, for, body composition, but these at-home metrics are so fun to be able to see, like,
Yeah,
how's
I
it going?
tested when I was in Dubai, or actually I was in, Riyadh, and I tested my
Oh,
lean body mass, and I was impressed
good.
because I hadn't worked out in a bit because I was traveling so much, so I was like, "Oh god, what are the numbers gonna show?" But what I will say is consistency really has proven to show up for you. We had discussed it earlier. I tell my patients this, your body has reserve. And so if you're feeding it in order to give it what you need in a moment of illness, when you're not able to work out, but your body is able to still to metabolize because it has the reserve and the stores, that's really what we're ultimately going for is creating something that can give back to you when you need it. And that's what happens typically with aging is we're not filling the stores and we're not investing in the stores with what we're discussing here in our health, but also these kind of tools that we can use. And then so when we get older and our metabolism is shot and our visceral fat is increased and our inflammation is sky high, your body has no reserve to give back to how do I fight these things off or how do I decrease them?
Yeah, absolutely. I love that. All right. Well, thank you guys all for being here. Thanks for
Yes.
being on the
Yes.
pod, Dr.
I'm
Jessica.
so excited.
Can't wait
Thank
for
you
this
so
to
much for
come out.
having me. Yeah.
This is such a pleasure.
Thank you everyone for being here.